Greetings. I am Dr. Jung Hyun-jun of Yonsei Dental Clinic. For a successful implant, rather than placing it quickly, you need to place it correctly. In order to do it correctly, you need to open flap and you need to design your flap appropriately. I'm going to talk about the design of flap and how you open it and the necessary surgical instruments. First, let's look at the contents. To open flap, the flap design needs to be good. And after that, following the flap design you have in mind, you need to make accurate incision. In the area for incision, the alveolar bone state is very important, and I'm going to talk about flap elevation and design for each surgical site, and I'm going to show you clinical cases. Finally, I'm going to talk about the surgical instruments that I use frequently for flap elevation. Let's begin. Designing flap well. What does this mean clinically? In our head, before we make incision following the image that we have, I'm going to talk about what clinicians should consider. You need to understand where the anatomical structures are. If you come across mental foramen and mental nerve, the incision cannot be made and surgery cannot be proceeded. In the lower posterior, incision should not be made too lingually. Lingual nerve is very close with the third molar. In order to prevent this, before surgery, you need to evaluate CBCT. Also, if you're a novice, you need to elevate flap sufficiently for visibility. Next, for implant placement, when you open flap, you need to reflect periosteum from the bone. When the extraction socket is not fully healed or upper anterior, if the muscle fiber is attached to the bone surface across the membrane, you need to minimize damage to periosteum and open full thickness flap. If bone graft is planned, exposure of clean bone surface is essential. Flap elevation is the starting point and the end point for perfect surgery. If you make incision in the wrong position, no matter how advanced your technique is, it will affect the prognosis and healing. And I would like to say that you need to open flap thinking of how you're going to close it. If you're going to do ridge augmentation after flap elevation, you need to consider the fact that at times, due to releasing incision, blood flow to the flap becomes unfavorable. And this can lead to necrosis in the flap. Therefore, position of crestal incision is very important. Also, if the vertical incision is included in flap formation, I would like to emphasize that the flap should be in the shape of trapezoid for blood flow. After doing many surgeries in this way, if you continue to reduce the size of flap, you'll be able to conduct the surgeries without failure. Minimally invasive techniques. It is favorable for healing, but you need to calculate and form flap depending on different surgery situations, and this requires a lot of experiences. Let's look at the things to consider when you're placing an implant. In the implant placement position, you need to open flap there. Therefore, the position of the incision is very important. When you make incision on the alveolar crest, when you do it more palatally or lingually, you'll be able to gain better visibility and accessibility. and the incision needs to be made within the scope of keratinized tissue. The reason is you can prevent unintentional damage to the anatomical structure, and after that, suture after surgery becomes more easier. Third, additional flap damage can be prevented. Appropriate position and appropriate length vertical incision needs to be made when you open flap, and I'm going to talk about this later. The final thing to consider is mesiodistal length of the flap. At times, in cases where the most distal tooth are missing, if you form flap too short, it may be unfavorable to place the implant in the most distal area. I'm sure you'll be able to overcome such issue later, but before you garner such experiences, you need to use calipers and other additional instruments to minimize your mistake. Consider implant placement position when you design your flap. As you can see in this case, in lower posterior, there has been a lot of resorption. Considering the factors that I've mentioned earlier, the flap was elevated. Buccolingually sufficient flap was elevated and surgical site was completely exposed. Horizontally, there was a lot of resorption in terms of bone width, and you can fully understand where the mental nerve is, and therefore sufficient amount of bone augmentation was made possible. However, in this case, if you're only fixated on the concept of minimal invasiveness, then sufficient amount of bone augmentation for implant placement will not be possible. The flap design and the clinical meaning it holds is directly related to visibility and accessibility. You can access a specific surgical techniques through many clinical literature and seminars, but if you're a novice, there's a difference between what you know and what you can do. And I think the reason is directly related with visibility and accessibility. In surgery, you need to understand patients' cheek, lips, and you need to form flaps that is fitting with the different surgeries. You need to elevate flap accurately and without damage, and this is the basic. If you get this right, specific surgical techniques, you can garner it with repeated experience. You can see horizontal bone resorption here, and you'll be able to come across these cases almost every day clinically. And before you make incision, you need to analyze a couple of important factors with CBCT analysis. First, whether you're going to do bone graft only or whether you're going to place implant together. Second, implant placement position. Third, you need to understand where the mental nerve is, which is a very important anatomical structure. With analysis, design your flap, and the alveolar crest incision, you need to understand the buccolingual position and the limit as to how much it can be extended, whether you're going to do vertical incision anteriorly and posteriorly. If you're going to do it, how long will it be? And if there's a bone irregularity, finally, how much keratinized tissue do you have? These factors need to be considered. If flap has been sufficiently elevated, there's no problem in placing your implant, doing bone graft, and fixing the membrane. In my opinion, appropriate positioning and length of vertical incision will help significantly in visibility and accessibility. This is before bone graft. Surgery has been proceeded up to this point. Now you need to do suture and close the flap. A lot of bone graft has been done, so it can be difficult to get primary tension aversion closure. If so, you need to do incision, releasing incision to relax the flap. If just because suture level increases, you avoid the vertical incision and only do interclavicular incision, it'll be difficult to do releasing incision. Let's look at the factors that consist of the flap. Basically, there is one horizontal incision on alveolar crest. If necessary, at the end of horizontal incision, add vertical incisions. If you're doing vertical incision, the length is important and it should cross at least the mucogingival junction for flap elasticity and relaxation. There is clinical implication for vertical incision. You can limit the surgical site and also do sufficient amount of flap elevation for surgery. If vertical incision is not made, in order to get sufficient visibility and accessibility, you need to do interclavicular incision extended significantly towards the front. After suture, this will become dead space and can become a major obstacle in initial healing. By adjusting the number and position of vertical incision, you can adjust the level of visibility and accessibility during surgery and the level of suture and healing. Regarding suture, the complexity is much higher in posterior vertical incision compared to anterior vertical incision, so it is better to do anterior vertical incision. However, if you require augmentation as well as implant placement for visibility and accessibility, I recommend 2 vertical incision flap design. If you have to do a lot of bone graft, you can do mesial vertical incision 1 or 2 teeth away, and that is called wide remote incision. This allows for easy flap suture after a lot of bone graft. If you have a larger pouch, you can put in more cookies. That is the concept. Through clinical case, I'm going to talk about how to do case selection. As you can see, if surrounding alveolar bone is sound, and if you need to place the implant in the anterior region, you don't want to lose any of the surrounding tissue. Unnecessary and excessive flap formation can affect aesthetic results, so I recommend flapless surgery. The choice of not to open a flap can be an important part of flap design. After bone graft and implant placement, if you're only going to do secondary surgery like this case, or if bone is sufficient and only implant placement is planned, you can just make 1 vertical incision mesial or distally to gain sufficient visibility and accessibility. However, as shown in this case, what shall we do if there is severe horizontal and vertical resorption? Major bone defect in upper posterior, it's much more difficult to access compared to lower posterior. 2 vertical incision needs to be made to do sufficient flap elevation. Let me tell you an interesting saying related to surgery. A deft surgeon does incision slowly and really quickly does flap elevation, and a beginner does incision really fast and slowly elevates the flap. If accurate periosteum cut is complete in an ideal flap design, flap elevation is automatically done. What kind of principles are there for accurate incision? First, you need to have a stable ring finger or pinky rest. Use blade curves and not the tip. If it is accessible, incision needs to be made towards the surgeon. If it is the opposite, the blade, once it parts from the bone, you may momentarily lose control of how it progresses and it can lead to accidents. Therefore, when you make an incision, you always need to understand what the bone surface is like below and also the position of important anatomical structures that should not be damaged. In the lower, on the lingual side of anterior region, the submental artery, buccal to premolar area, the mental foramen, lingual to the third molar area, the lingual nerve needs to be noted of. And in the upper, be aware of venous plexus posterior to the upper posterior area. Regarding flap, following incisions are made. Horizontal incision is made on alveolar crest, sulcular incision following adjacent teeth, and vertical incision that increases visibility and accessibility and limits the surgical site. The horizontal incision made on the center of alveolar crest is called crestal incision, and if it goes slightly lingual or buccal, the incision is called subcrestal incision. Crestal incision is made when there is sufficient bone width and sufficient keratinized tissue. It is made centered on the alveolar crest. However, more often than not, we come across narrow bone width and not fully healed extraction sockets. And we have to pay more attention about where you make incision. If you make horizontal incisions slightly lingually, implant drilling point is exposed, so it makes the surgery easier, and in the case of one-stage surgery, you can slightly shift the keratinized tissue buccally, so lingual subcrestal incision is clinically used very often. At times, due to slow healing in extraction socket, there can be soft tissue defect or epithelial tissue may not be fully mature, and in those cases, do subcrestal incision to avoid that. It will make surgery after flap elevation and suture much easier. Now, I'm going to talk about surgical sites and flap designs and the way we make incision. And I'm going to talk about this by showing you clinical cases. First is lower anterior, and bone width is quite narrow. And in this case, after implant placement, bone graft and immediate prosthesis was planned. After flap elevation, implant was placed. Because the bone width is narrow, surgical guide template can help in accuracy. However, if you connect the guide up until placement, it becomes close to blind technique. You need to be aware of flap control. When you do vertical incision in flap elevation, you need to adjust the angle of incision so that the base is designed to be wide in order to secure sufficient blood supply. Bone graft and membrane application was done. Because of bone graft amount, buccolingually, slight releasing incision was done and flap was closed. This is after final prosthesis. Second is upper posterior case. There's severe horizontal and vertical bone loss, and through CBCT analysis, bone graft amount and post-surgery primary aversion closure was kept in mind when flap was designed. In other words, a sufficient vertical releasing incision was done. After that, sufficient bone graft was done. Osbuilder type 3 was used to maintain space, and additional collagen membrane was used. Suture was done. Instead of proximal releasing incision, as shown on the right, if I had done papilla preservation incision, during flap closure on the papilla side, primary closure would have been very difficult, and flap dehiscence as well as infection might have occurred from there. you need to consider that there can be a little bit of gingival recession in adjacent teeth, and you need to consider pro and cons of GBR success rate and decide on flap design. This is after healing. Compared to before surgery, satisfactory bone augmentation has occurred. Finally, I'm going to show you lower posterior case. Implant placement as well as vertical augmentation was planned and guided surgery was used, and vertical augmentation was done at the same time. The buccolingual position of crestal incision needs to be decided well in order to minimize damage on the flap during drilling. Buccolingual flap elevation was done, implant was placed, vertical augmentation was conducted, non-resorbable membrane was fixated, and suture was done. 2 vertical incisions were used, so surgical site was limited, but at the same time, sufficient visibility and accessibility was secured. In addition, because I did vertical incision, I was able to do releasing incision more easily. This is a very important point in success of vertical augmentation and early healing. After 6 months, this is right before secondary surgery. Accurate flap design and flawless flap elevation and retraction can affect post-op healing, and this case really shows that point. Finally, I'm going to talk about surgical instruments necessary for flap elevation. Normally, number 15 blade is used. It is most suited for oral treatment. At times, if there's irregularity in bone surface, and because of the angle, number 15 blade cannot reach the periosteum. That is the case for an area where tooth is lost and posterior to the most distal tooth. And number 12 blade can be used to sever the collagen fiber in the cervical area. 15C blade is slimmer than 15 blade, so it has better accessibility. I prefer this. Blade is connected with blade holder. As mentioned earlier, number 15 blade is used for crestal incision and vertical incision. 12 blade is used for collagen fiber cut of distal surface of adjacent teeth in the posterior region. And it is also used for periodontal collagen fiber cut that number 15 blade cannot do. You need to do flap elevation very quickly after accurate incision. For flap with thick and wide keratinized tissue, you can use Mold 9, and for thin and delicate flap, you can use P24G. In the posterior maxilla, when you open thick flap, you can use 13K, which is a type of back action chisel. Flap elevation was done. When you do flap elevation, the left hand or assistant needs to maintain and guide the flap. For this, you can use selding, which is thick and wide and intricate, or you can use a free child retractor, which you can use for different flap thickness and size. These tools are used to retract flap. You can choose depending on your preference. In the case of Minnesota retractor, flap, lip, cheek can be guided at the same time, and it's very convenient. However, your left hand needs to grip the instrument, so there can be limitation in detailed surgeries, and this volume is quite significant, so it can interfere with the available space for surgery. The 3 retractors are available, and you can use them depending on your style and indication. How did you like today's lecture? I would like to summarize what I hope you'd take home. First, you need to have ideal flap design and accurate and clear incision to do sound flap elevation. This has critical effect on
post-op primary intention healing. If you're only placing implant in the posterior region, slight secondary intention healing may be allowed. However, in the case of anterior, where aesthetic is important, or if you require bone graft and impeccable initial healing, primary intention healing is essential in these cases. Second, incision needs to be made so that periosteum is cleanly severed. To do this, vertical force is applied on bone surface, and that occurs quite a lot of times. However, if there's a lot of bone loss, or if the socket is destroyed and if the bone surface is irregular and there's damage to the anatomical structure, at times it's difficult to make a decision. Your heart sinks in those cases. Therefore, CBCT analysis is very important in flap designing process. Third, you need to understand the characteristics of surgical site and flap before surgery and use appropriate surgical instrument to do quick, accurate, and damage-free full-thickness flap. You need to be experienced in doing this. In deciding flap designs and surgical instruments, you need to understand your theories regarding this, but you need to understand the patient's state, surgical site, and various factors. Please remember this point. Master Course continues to support you in your footsteps towards a successful implant placement. I'll come back with an even better lecture next time. Thank you for watching.
고맙습니다.